Alright guys, let's get busy talking about the transient complications of pregnancy. If you haven't already taken a look at our physiology of pregnancy video, I might check that out first because some of the physiology there is going to really inform a lot of the pathology we're going to talk about in this video. So let's go ahead and get started by talking about our supine hypotensive syndrome, which is going to be a really interesting phenomenon in which we see supine hypotension, which is not a normal finding in most people. We usually see hypotension when patients stand up, and we call this orthostatic hypotension. However, in this case of supine hypotensive syndrome, it's also called aortocaval compression syndrome, and this informs a lot of the pathology going on here. So essentially, we have a big old baby sitting up on top of the aorta and the inferior vena cava inside of our pregnant person. And so you can imagine that the gravity of this really heavy fetus, which could be upwards of 6, 7, 8 pounds during development, is going to be pressing down on these major vessels. And so what's going to happen is, in terms of pressure down on the aorta, the baby is essentially going to clamp off its own blood flow, because we know the aorta of the mother is going to supply the placenta. And so if that is being clamped down on, we can expect to see things like uteroplacental insufficiency, and this is going to lead to restriction of fetal growth. So let's review: the compression of the maternal aorta by the growing fetus reduces placental blood flow, and this can lead to possible pregnancy loss. And then we also have compression of the inferior vena cava, which is largely going to affect the symptoms of the pregnant person. So as the inferior vena cava is responsible for preload and things like that, if it's being pressed on, we're going to get hypotension because we're not going to get enough blood flow back to the heart. So let's review: compression of maternal IVC by growing fetus leads to hypotension while supine. So this is a really interesting physiology that is unique to pregnancy, and it is unique to the supine positioning. Next, let's move on to talk about peripheral edema. So in our physiology of pregnancy video, we talked about the fact that mothers undergo a dilutional anemia. They are rapidly expanding their blood volume, and it takes a while for the production of red blood cells and proteins and other solutes in the blood to keep up with that volume expansion, and so they have really relatively dilute blood. And what happens here is this dilutional anemia is going to lead to decreased oncotic pressure. Remember, oncotic pressure is created by things like solutes and red blood cells and proteins like albumin in the blood. And if we have dilute blood, our oncotic pressure is going to be reduced. And remember, oncotic pressure pulls fluid back into the vasculature. And so if we have a reduced oncotic pressure, fluid is going to leak out into the interstitial space, and this is going to present as edema in the pregnant person. Moving on now, let's talk about gestational thrombocytopenia, and this is a very similar thing going on here. We have this dilutional effect from volume expansion, and this is going to reflect with relatively low platelet counts because the concentration of platelets in our blood samples is going to be low. Usually this is not significant enough to cause symptoms because luckily humans can do pretty well with pretty low levels of platelets before they start getting symptoms, but it's important in someone with lowering platelets levels that you rule out some other important pathologies, namely ITP and HELLP syndrome. So in the case of ITP, we might be worried if we started seeing things like petechiae and bruising and abnormal bleeding. And in the case of HELLP syndrome, we're going to be expecting an unstable patient with like elevations in liver enzymes as well as hemolysis, in addition to our low platelets, maybe some subcapsular liver hematomas. Let's really hope not, but that would be really extreme. But in terms of just low platelets, this is a normal finding that we can expect in pregnancy, and it's going to be without any major complications. Moving on now, let's talk about nausea and vomiting, and this is going to be due to beta-HCG. We know that beta-HCG is produced by the placenta during pregnancy. This is the cheerleader. It is encouraging the corpus luteum to continue making progesterone for the first 10 weeks of pregnancy, and it's also going to have the side effect of causing nausea and vomiting. So in the first trimester of pregnancy, those initial 10 weeks when beta-HCG is really high doing its cheerleading, you normally hear pregnant people complain of morning sickness, and this nausea and vomiting classically happens in the morning in question vignettes and patient complaints, but this can really happen at any time of day. And some patients undergo extreme nausea and vomiting, and when it's extreme and unremitting, we are going to reclassify this as a disease process called hyperemesis gravidarum. So it literally means intense vomiting because you're pregnant, which is so sad. It sounds awful. Let's talk about hyperthyroidism hypothyroidism, and this is going to be also due to increased levels of beta HCG. And I think this mechanism is super interesting because beta HCG actually has a similar structure to thyroid stimulating hormone. And so essentially it's traveling through the blood and it's going to go provide agonism at the thyroid and say, hey, thyroid, we need more thyroid activity. And the thyroid thinks that beta HCG is equivalent of TSH. And so it's going to sense that, and the thyroid is going to get stimulated. It's going to produce T3 and T4. And we know that T3 and T4 have a number of effects across the body that are going to reflect as like an activation of metabolism and an activation making you alert, a lot of like hot and heavy and sweaty type symptoms. So we can expect mothers to present with things like tachycardia, diarrhea, heat sensitivity, and anxiety. And it would be important in this type of presentation to check thyroid levels to see, hey, are these symptoms due to like perhaps increased beta HCG agonizing the thyroid, or is it something else that we need to rule out? And then finally, let's talk about gestational diabetes. And this is going to be due to human placental lactogen, which is another hormone that is produced by our placenta. And this is responsible for helping the fetus grow. It is actually an analog of human growth hormone, which I'm abbreviating HGH, and it has strong effects on making the fetus grow, but it's also going to lead to insulin resistance in the mother. So it's going to increase insulin production, and this is going to lead to insulin resistance. And we know that insulin resistance can lead to diabetes, and so mothers can develop gestational diabetes because of the production of this hormone. So when it comes to a high yield review of all the topics we talked about today, it's really based in understanding the physiology. So here in our first three conditions, it was all about understanding fluid compartments and how fluid is going to move. And if you understand that, then all three of these pathologies make sense. And then in our last three pathologies, it was all about chemicals produced by the placenta, right? So our beta HCG causing nausea and vomiting, as well as agonism at the thyroid, and then the production of human placental lactogen leading to insulin resistance. So I hope you guys found this video helpful and enjoyable. I can't wait to see you guys in the next one. Bye!